Hi there, Mark from Capital Podiatry again, and today I'd like to talk to you about one of the most common conditions that we treat here, and that's plantar fasciitis, also known as plantar fasciopathy, plantar fasciosis, plantar heel pain. It has innumerable names, but basically it's pain around the heel and often through the arch of the foot. Now, with the plantar fascia, what it essentially is a couple of bands of fascia. Imagine it like tendon material that runs along the bottom of the foot. One end attaches to the heel, and then it fans out and attaches to the beginning of the toes and the front of the foot. There are essentially three bands. There's a medial plantar fascia, which goes from the heel through the arch of the foot and attaches to the big toe, and that's classically the one that gets inflamed. It's possible for the other ones to get it as well, but it's 9 times out of 10 it's the medial band of the plantar fascia. Now, the plantar fascia plays a pretty important role. It helps to support the foot and it helps in propulsion as well. And the way it functions is when you're walking along, when you go through a gait cycle, you put weight on the foot, then the foot, after it meets the ground, will roll in and flatten out to some degree. Now, it does that to unlock the joints in the foot. It effectively turns it into a loose bag of bones momentarily to absorb shock and adjust to uneven ground. Then as you go forward, the foot is supposed to roll out and all the joints lock up and you've got something firm to push off with. Now, the fascial bands under the foot are designed to stretch, to flex like rubber bands each time the foot rolls in. Of course, it'll flatten out and it'll lengthen and then it'll contract. And the fascia will accommodate that, and it helps, it actually winds up and helps propel the foot into that locking up phase. And it also supports the midfoot so it doesn't collapse as you're pushing forward. Now, it's possible for the fascia, particularly the medial band of fascia, to get inflamed. And there are a number of different reasons for it. Yes, weight can play a role, age can play a role as well. If you've got a job where you're working on hard floors, that can play a role. The most common ones I find though is a combination of this foot movement together with a sudden change in what you're doing. So a classic is someone who goes on holiday and wears thongs or sandals where they don't normally wear flimsy footwear. It can be someone who's getting back into exercise or suddenly increases their exercise or changes the type of exercise. Often there's a triggering moment where it's almost like the plantar fascia has been caught unawares and it's just not ready for it. So it gets inflamed, and it can be, the classic place is where it anchors on the heel, but it actually can happen anywhere along the fascia. Now, if you go to a doctor, classically the GP approach would be to send you for an X-ray. X-rays may pick up hints of plantar fasciitis. An ultrasound's actually better for it, and it often picks up a heel spur. So a heel spur imagine it as calcification along the line of the fascia. So, and it has to do with the traction of the fascia over the years against there. Now, heel spurs are no big deal. A lot of people have heel spurs and go through life and never know it. It's only if the fascia inserting on the heel around the heel spur gets inflamed that it's an issue. So don't freak if you get diagnosed with a heel spur. Unfortunately, often the next step for doctors is to send you for a cortisone shot. I've been told that it is the most painful injection there is. They basically use ultrasound to image the most inflamed part, and they get a needle, stand at the other end of the room and run at it and drive it up into there and inject it in there. I had a gentleman the other day who had the pleasure of a cortisone shot, and he told me that last year he had to pass a kidney stone, and that was preferable to this injection. So, and the issue with it too is this is a functional issue. So either the cortisone won't work or it'll only work for a while and everything will come back. So word of warning. So what do we do about it? Okay, so there's a number of things we do. We have to look at the anatomical reasons for it and deal with that. So often this inflammation is due to the foot rolling in too far or staying rolled in for too long through the gait cycle. So as the foot's going forward, the fascia is not doing what it should and it gets stressed. Now, compounding this, people often have a lack of mobility in the ankles due to tight calves, for instance. So if they can't flex forward on their ankle enough, they have to get that movement somewhere, and there's additional strain going on the plantar fascia. So we use a combination of techniques to attack this. So we use joint mobilizing to make sure that all the joints, particularly the ankle, are doing what they should. We do some fascial release work on the plantar fascia, and we look at things like, do we need to have an orthotic to address the functional issues going on with the foot, to give it greater support and help guide it through a more normal gait range of movement. And we do rehab exercises as well. Now, untreated with plantar fasciitis, it could bug you for up to 2 years, but if it's dealt with early with the appropriate treatment, we can generally knock it on the head in 4 to 6 weeks. And often keep you mobile in that time, because it's really frustrating having to stop training when you don't want to. So that's the ins and outs of plantar fasciitis. I hope this was useful.